Thanks for coming to our YouTube channel, American Medicine. In this channel, we discuss current information on various medical topics every Sunday at 6 p.m. Indian Standard Time, 6:30 a.m. Central Standard Time. Our aim is to spread the current information to all medical practitioners across the globe. If you do not mind, please spread this information to all medical practitioners across the globe. With that, let's move on to our topic, diabetic ketoacidosis in children. In this particular seminar, we are going to talk about history of DKA, epidemiology, pathogenesis, pathophysiology, complications, clinical manifestations, lab tests, diagnosis, and treatment. First, let us look at the history of DKA. The first detailed report of diabetic coma was entered in 1800. It took almost 120 years to detect insulin that was happened in the early 20th century. After 50 years, around 71 to 1990, the low-dose insulin protocols were introduced for DKA, and also the rate of fluid administration in children were questioned at that point. Only in the last 24 hours, UK guidelines and the ADA guidelines for the DKA treatment was established and published. Currently, the mortality rate is less than 1%. It was 50% almost 70 years ago. Two-thirds of DKA happens in type 1 diabetes mellitus, and one-third happens in patients with type 2 diabetes mellitus. Average annual hospitalization rate has increased significantly from 6.3% to 54.9% from 2009 to 2014, meaning we admit more patients with the DKA in the hospitals. Recurrent DKA often occurs in small number of adults and children who have behavioral, social, and psychological problems. So it's very important if the patient comes with recurrent DKA to look into behavioral and social and psychological issues. In developed countries, the current reported death rate is less than 1% across all age groups and sex. Data from India shows 30% mortality in those presenting with DKA. The mortality rate in sub-Saharan Africa is 26 to 41.3%. This is an article published in 2016 shows 30% mortality out of 270 patients. The pathogenesis of DKA revolves around those 5 components. 1. No glucose utilization, usage of alternative energy sources, osmotic diuresis, hyperosmolar state, and compensatory mechanisms. Absolute or relative insulin deficiency associated with increase in counter-regulatory hormones such as cortisol, growth hormone, glucagon, and catecholamines play a significant role in DKA. Insulin deficiency leads to increased gluconeogenesis and impaired glucose uptake and use in peripheral tissues. High glucagon, catecholamine, and cortisol concentrations relative to insulin levels stimulate gluconeogenic enzyme activity. It augments hyperglycemia. Increase in concentration of counter-regulatory hormones associated with severe insulin deficiency leads to lipolysis and release free fatty acids and glycerol in circulation. Free fatty acids or oxidize to ketone bodies in the hepatic mitochondria. The three well-known ketone bodies are acetone, acetoacetate, and beta-hydroxybutyrate. Exhaled acetone gives classic fruity odor. Acetoacetate and beta-hydroxybutyrate are acidic. Accumulation of ketoacids leads to a decrease in serum bicarbonate concentration. NN gap is increased because of accumulating ketoacids. When the pH is below 7.35, intracellular biological systems begin to fail. Irreversible damage happens when the pH is below 6.8. Electrolyte disturbance. Insulin maintains potassium concentration within intracellular fluid. Lack of insulin causes potassium to move into the extracellular space from intracellular area. Osmotic diuresis causes potassium depletion along with polyuria and sodium and phosphate depletion. Hypovolemia stimulates aldosterone release that causes reabsorption of sodium and excretion of potassium in renal tubules. In addition, severe hyperglycemia and the occurrence of ketoacidosis results in pro-inflammatory state. The pro-inflammatory state inhibits insulin signaling or increased lipolysis, resulting in free fatty acids. It also impairs insulin secretions and reduces insulin action. The free fatty acids induce insulin resistance and impairs endothelial action. Inflammatory state has been hypothesized to be involved in causing complications of DKA in children, particularly cerebral edema and cerebral injury. This is an old model still being used during the treatment of DKA. When there is a hyperglycemia, it causes hyperosmolar state around the cells. As a result, the cells, especially neuronal cells, develops idiogenic osmoles, such as taurine and myoinositol, to keep the integrity of the cell. When the DKA is being treated, the glucose level falls down. That causes relative increased hyperosmolarity within the cell. As a result, water moves into the cell that causes cerebral injury or cerebral edema. This slide shows what we have discussed in the past 3 slides. Insulin deficiency causes decreased glucose utilization that activates starvation pathway in adipose, muscle, and hepatic tissue, which in turn increases counter-regulatory hormones such as cortisol, glucagon, epinephrine, and growth hormone. It also increases pro-inflammatory cytokine production. That causes hyperdynamic and hypertensive state. Both insulin deficiency and increase in counter-regulatory hormones causes lipolysis that result in triglycerides and glycerol. This in turn goes into hepatic mitochondria converted into ketone bodies. The ketone bodies causes ketoacidosis and hyperventilation. In addition, this gluconeogenesis and glycogenolysis and decreased glucoutilization that all causes hyperglycemia that result in osmotic diuresis and dehydration. The dehydration not only causes free water loss, and also it causes sodium, potassium, and phosphate loss. The late stage, severe dehydration with oliguria, acute kidney injury, severe hyperglycemia, hypotension due to hypovolemic shock with lactic acidosis, obtundation, and arrhythmias. Typically, hypotension doesn't happen in children that often, but it could happen. Osmotic diuresis happens when the serum glucose exceeds 250 milligram per deciliter. It causes excretion of glucose in the urine that also leads to polyuria, loss of potassium in the urine called kaliuresis, loss of sodium in the urine called natriuresis, and inability to reabsorb phosphate, that means loss of phosphate in the urine. This is an important equation one should remember in dealing with DKA and how osmolarity is maintained. Osmolarity is maintained by these three important components: sodium, glucose, and BUN. The formula is 2 times sodium plus glucose over 18 and BUN over 2.8. The normal serum osmolarity is 285 to 295. In patients with hyperglycemia, and what we think most of the time, 2 times sodium is the osmolarity. But when you have hyperglycemia or hyperuricemia, the osmolarity may be much higher than just 2 times serum sodium. Some of these patients, when they presented, they will have a spurious hyponatremia. By using the calculations, you will know what is the serum osmolarity in this patient. The pathophysiology of DKA involves free water loss, electrolyte loss, and acidosis. If it becomes profound, it can lead to dehydration and acute kidney injury. The free water losses happens because of osmotic diuresis, as we discussed earlier, and also vomiting and lack of oral intake. The sodium shifts into the extracellular space. As we discussed earlier, in addition to water loss, there is a loss of sodium called natriuresis, potassium, kaliuresis, and phosphate loss. Acidosis shifts the potassium into the extracellular space. Even though there is a significant total body depletion of potassium, initial serum potassium may be high because of the acidosis. These patients may have compensatory respiratory alkalosis. When the osmotic diuresis stops, hyperglycemia will become more profound. Serum sodium and potassium will be very high. DKA is graded into 3 categories in pediatrics: mild, moderate, and severe. The mild DKA is defined when the pH is between 7.3 to 7.2. The bicarbonate level will be less than 15. Moderate DKA, the pH would be between 7.1 to 7.2. The bicarb would be less than 10. In severe category, patients will have bicarb less than 5 and venous pH would be less than 7.1. It's more important to understand more severe the DKA, the slower you correct. When you see a very sick patient, there will be urge to treat them aggressively. That will cause more harm to the patient than doing good. I'd like to show you the diagnostic criteria by different societies. As you can see here, International Society of Pediatric and Adolescent Diabetes shows mild less than 7.3, moderate less than 7.2, and severe less than 7.1 venous pH. And the corresponding bicarbonate will be less than 15, less than 10, and 5. The British Society classifies only having a diabetes, DKA or not. Simple. There is no gradation within the diabetic ketoacidosis. American Diabetic Association for adults have a little bit different criteria to define mild, moderate, and severe. And all those societies agree the beta hydroxybutyrate should be more than 3.0. So what are the precipitating factors in pediatric DKA? The most common in the United States is non-compliance. The second common is pump malfunction, insulin pump malfunction. Infection can cause DKA, but it is very rare. As we discussed earlier, 30% of the DKA, 30% of the new onset diabetes present as DKA. But that's not true across the globe. As you can see in the United States, the more common reason is poor treatment adherence, non-compliance. But the rest of the world, infection is the most common cause of DKA. That includes United Kingdom. As we discussed earlier, the DKA, the new onset diabetes present, especially IDDM, present as DKA in 30% of these patients. The reason? Lack of prompt recognition of new onset type 1 diabetes. In established diabetic patients, the reason for DKA are as follows: insulin omission, infections like GI and vomiting, gastrointestinal tract diarrhea and vomiting, poor diabetic control, previous episodes of DKA, unstable or challenging family or social circumstances, adolescent age, peripubertal girl, limited access to medical services. Sometimes psychological factors play into role, especially things like disordered eating in girls, fear of weight gain with good glycemic control, diabetes-related stress, fear of hypoglycemia and rebellion from authority. In the United States, we see more and more cannabis use causing recurrent DKA, corticosteroids, sympathomimetic agents, and usage of pentamidine and new onset IDDM, which we discussed earlier. So what are the electrolyte derangements can happen in DKA? Sodium, potassium, and phosphorus will be depleted in patients with DKA. The most important is potassium. Let's say sodium. Whether it be high or low depends on the severity of dehydration and the duration of DKA. More dehydrated, the serum sodium, at least corrected serum sodium, would be high. Potassium acidosis causes shift of potassium from intracellular to the extracellular. So in presence of acidosis, the serum potassium level will be high. But the body potassium will be low because potassium loss from osmotic diuresis that result in total body depletion. The phosphorus also will be lower in patients with DKA because of inability to reabsorb in renal tubules. So all these patients will be hooked up to the monitor. So by looking at the EKG, one can see whether the patient has moderate hypokalemia by observing U wave, or severe hypokalemia with observing the prominent U wave. In patients with moderate and hyperkalemia, one can see in peak T wave. Irrespective of the EKG changes, always check the serum potassium level. So what are the signs and symptoms of DKA? The classic clinical signs of IDDM or diabetes: polyuria, polydipsia, polyphagia, and weight loss. The clinical signs may progress rapidly and include vomiting, abdominal pain, dehydration, weakness, and lethargy. Abdominal pain and ileus can result from potassium depletion, acidosis, and poor splanchnic perfusion. Dehydration causes tachycardia, delayed capillary refill time, poor skin turgor, and dry mucous membranes. Customal respiration occurs due to central and peripheral chemoreceptor stimulation from ketoacidosis. Ketoacidosis may result in a fruity odor to the breath. This picture depicts various signs and symptoms associated with the DKA. They can have polydipsia, polyphagia, lethargy and stupor, blurred vision, smell of acetone, which is fruity odor, customal respiration, rapid fast breathing, polyuria, ketonuria, and glucosuria, nausea, vomiting, and abdominal pain. When compensatory mechanisms are overwhelmed, children with severe DKA may present with hypotension, shock, and altered mental status. The most feared complication of DKA is severe neurologic injury and development of cerebral edema. Always do GCS scoring in all patients with DKA. First time, baseline, and also subsequently every 1 to 2 hours for the first 12 hours till the DKA resolves. As you mentioned earlier, the DKA is categorized into mild, moderate, severe. These patients need to get basic metabolic panel to look for bicarbonate level and anion gap. This patient will have increased anion gap, but to make sure this increased anion gap is not as a result of lactic acidosis or salicylate poisoning. DKA complications. Cerebral edema, even though it happens in 0.3 to 0.9% of the patients, but it is the most feared complication in children. This is rare in adults. Cerebral edema causes 21 to 24% mortality and 15 to 26% neurologic sequelae. The next common or more common complication than cerebral edema is electrolyte derangements and cardiac arrhythmias. It could be fatal too. Venous thrombosis observed especially in those patients who have central line placement. Mucormycosis, especially in poor diabetes controlled with DKA. It's I have not seen in the last many years, but I used to see when I was in New Delhi, India. Acute renal failure. Most of the acute renal failure as a result of DKA is pre-renal stage 1. Very rarely it progresses to stage 2 and stage 3. Acute pancreatitis can be the complication, but it's uncommon in children with type 1 diabetes mellitus. The most feared complication, cerebral edema and DKA. The possible risk factors are less than 5 years. Increased DKA severity or dehydration, severe acidosis or severe DKA patients prone to develop cerebral edema than mild to moderate. Low PCO2, that means severe acidosis, high BUN, and giving bicarbonate bolus is associated with cerebral edema. Lack of sodium increase with correction. When the patient presents initially, serum sodium level, at least the measured serum sodium level is very low. As you treat the patient, the serum sodium level should come up. If that doesn't happen, those patients are prone to develop cerebral edema. Rapid decrease in serum osmolality, either by giving more fluid or giving insulin bolus that can precipitate cerebral edema. So what are the symptoms? Headache, lethargy, altered mental status, and increased blood pressure, especially diastolic blood pressure more than 90. These patients can have subtle signs like headache, irritability, nausea, emesis, but sometimes they can have decorticate and decerebrate posturing, abnormal breathing pattern, and cranial nerve palsy. How do you treat them? Mannitol or hypertonic saline. When you use mannitol, use the dose 0.5 to 1 gram per kilo. When you do a 3% hypertonic saline, use 5 ml per kilo. My preference is hypertonic saline, not mannitol. Mannitol also causes osmotic diuresis. How to prevent cerebral edema? Start isotonic fluid during the bolus as well as during the correction of DKA. So what are the risk factors of cerebral edema? That was published in 2001 in NEJM. They found something which was not known before. The most important is treatment with bicarbonate associated with 0.008, associated with cerebral edema on top of increased BE and creatinine, and low PCO2 and the serum sodium concentration doesn't respond to the treatment. The older theory of cerebral edema is a rapid rehydration with the hypertonic fluid with the resultant fluid shift due to rapid decrease in osmolality between extravascular and intravascular intracranial compartment. The newer theory for cerebral edema is cerebral hypoperfusion and reperfusion injury, neuroinflammation, and vasogenic edema, and increased permeability of blood-brain barrier. This picture shows CT scan of the head with cerebral edema. As you can see here, absence of gyri and sulci, complete effacement of all cisterns, small ventricle, and decreased gray-white differentiation. Cerebral injury is the most well-recognized and most feared complication. It occurs in 0.3 to 0.9% of DKA episodes, but it is associated with high mortality, 21 to 24%. The morbidity associated is 20 to 26%. Although the severe cerebral injury occurs in less than 1% of children with DKA, mild cerebral injury occurs much more commonly, possibly in majority of these children. Subtle deficits in memory, attention, and IQ have been reported in children with type 1 diabetes mellitus. So it's very important in preventing DKA. Cerebral injury can exist at the time of presentations before starting treatment, but it's more common during the first 12 hours of treatment. Change in mental status, headache development during treatment, and recurrence of vomiting are indicative of cerebral injury. As you mentioned before, the risk factors: severe acidemia, severe deficits in circulatory volume, and young age group are more prone to develop cerebral injury. I have done a seminar on fluid management in hospitalized patients that explains why cerebral edema more common in children than in adults. If you have a chance, please go through it. It explains a little bit more detail. The warning signs: headache, irritability, hypertension, diastolic blood pressure more than 90, increased drowsiness, unresponsiveness, altered mental status, coma, bradycardia, craniopathies, and other abnormal neurologic signs. As you mentioned earlier, GCS needs to be done at the baseline and needs to be monitored every 1 to 2 hours during treatment till the DKA resolves. What are the other complications? Cerebral injury, even though it affects 1% of children and adults, it is the most feared complication we discussed extensively before. Acute kidney injury, most of them are prerenal, that to stage 1. Stage 2 and stage 3 can occur, but most of them are prerenal. If you treat them aggressively or treat them appropriately, I will not say aggressively, treat them appropriately, they all recover. Large vessel thrombosis happens in 50% of children when you do central line placement in those patients. Most of these kids need peripheral IV, 2 of them. Just place it, you will be okay. Subclinical interstitial pulmonary edema have been reported, but it's inconsequential, so during treatment, it does not pose any issues. Symptomatic pulmonary edema is very rare in adults and children. Pancreatic enzyme elevation seen in 20 to 30% of children and also in adults, but the frank pancreatitis is uncommon in children. It is maybe more common in those patients with hypertriglyceridemia. Prolonged QTc interval is common in children, but does not cause any significant ventricular arrhythmias But when you have ventricular arrhythmia, it's not caused by electrolyte abnormalities, so one should look at QTc. Diastolic dysfunction has been seen in 47% of the children. Symptomatic cardiomyopathy is rare, but it can occur. Rhabdomyolysis should be suspected when the kidney injury takes longer time to recover, especially when it is associated with influenza. Asymptomatic hypophosphatemia is more common, but the severe hypophosphatemia, meaning the phosphate level less than 1.5 or 1, is very rare. Intestinal necrosis, GI bleeding, more common in adults. It is very rarely observed in children. So how to treat? Careful fluid resuscitation, insulin administration, electrolyte replacement, and close monitoring for signs of cerebral edema. Initial management includes fluid resuscitation with isotonic fluid. That's very important. Fluid replacement should begin before starting insulin therapy. Calculation of fluid administration, including replacement from the losses and maintenance fluid, should be estimated over 24 to 48 hours, preferably 48 hours, with either half normal saline or normal saline, or any other balanced salt solution may be used like lactate ringers, Hartmann solution, or Plasmolite. In practice, we use 1.5 maintenance. We will not go into the extent of calculating deficit and maintenance and doing the infusion rate. In practice, this is what we do here across the nation. There is a technique called two-bag method. Bag 1 will have normal saline with potassium additives. Bag 2 will have D10 with normal saline plus potassium additives. When the sugar is more than 250, we will give only the bag 1, which has normal saline with potassium additives. I can explain to you what the potassium additives means. When the sugar falls below 250, then we will give half of bag 1 and half of bag 2. That gives D5 equivalent. That is normal saline with potassium additives 50% and D10 normal saline and potassium additives 50%. When the sugar falls below 200, we further decrease normal saline to 25% and 75% we increase to D10. That will give 7.5% dextrose. When the sugar falls below 150, we give only D10 normal saline with potassium additives. When the sugar falls below 100, either we will give a simple pause to the insulin. Some people go up on dextrose containing solution from 1.5 to 1.75% maintenance. With this method, I have not seen single mortality in the last 20 years. Okay, let me decode what is potassium additive means. In children, we put 40 milliequivalents of potassium in both the bags. So that means 40 milliequivalent per liter. Out of the 40 milliequivalent, we will add 20 milliequivalent of potassium acetate and 20 milliequivalents of potassium phosphate. That will avoid more chloride because we are already giving 0.9% sodium chloride, which has 150 milliequivalent of sodium chloride. So 150 milliequivalents of chloride. So we do not want to add potassium chloride, instead potassium acetate, and acetate helps. Acetate goes through the liver, converts into bicarbonate. And the phosphate will replenish the depleted stores of phosphate in the body. This one works beautifully well. So rapid fluid administration should be avoided. The dilution decrease in serum glucose decreases serum osmolality. As a result, it causes cerebral fluid shifts and cerebral edema. Even though this theory is old, but it is being practiced, it is being used in the practice currently across. We never do rapid fluid administrations in patients with diabetic ketoacidosis. Another issue with this model is hyperchloremic metabolic acidosis. It may contribute to the, as I said, hyperchloremic metabolic acidosis and low serum bicarbonate level. The hyperchloremic metabolic acidosis should be considered when you have a non-anion gap metabolic acidosis and low serum bicarbonate. Hyperchloremic metabolic acidosis as such doesn't have any bad effect on the body. The only thing is, if you follow bicarbonate to shut off the insulin and IV fluids, then you may get fooled. As a result, always watch bicarbonate, chloride, and anion gap. When the anion gap becomes normal, that means ketoacids is already gone. The so-called low bicarbonate is because of hyperchloremia rather than ketoacids. So one has to think that way, then you will be fine. Some people may say, why do you want to do a normal saline? Why don't you use half normal saline? You can avert hyperchloremia. Yes, you can. But thing is, there is a potential of developing cerebral edema. As I had mentioned before, there is a 24% of mortality and 26% of neurologic sequelae, and the minor brain injury is more abundant than what we see at this point. Well, that particular theory has been questioned and put to study. That's called PECARN DKA fluid study. The PECARN DKA fluid study analyzed or experiments 4 different arms. One is the fast administration of half normal saline, fast administration of normal saline versus slow administration of half normal saline and slow administration of normal saline. What is fast administration of half normal saline? During the initial 12 hours, they replace half of the fluid deficit plus maintenance, and the remaining 24 hours, the remaining half of the deficit and maintenance fluid. So in 36 hours, they correct the deficit plus maintenance with half normal saline. In the normal saline group, the same mode, instead of half normal saline, they use normal saline that it used. In the slow group, the way they did it, they calculated the deficit plus maintenance fluids, then they evenly distributed over 48 hours. Instead of 36 hours, evenly distributed. This is called slow correction. One arm had just half normal saline, another arm had normal saline. When they look at GCS change among all those 4 groups, it is not clinically significant. There is no significant change, as you can see, 10, 11, 11, 16. The secondary outcomes, they follow these patients 1 year out of DKA episode by looking at digital span recall test forward and backward. They did not find any difference either. The conclusion of the study is, doesn't matter whether you use half normal saline or normal saline. The proponents of no hyperchloremic acidosis would say, why don't you use half normal saline? Yes, you could. But most of the people, including me, I still use normal saline. At least it is not causing damage. There is potential of causing cerebral edema. It's still there. I would rather do this one than half normal saline. That's what we are practicing at this point. Insulin therapy should follow initial replacement at a rate of 0.05 to 0.1 unit per kg per hour. The expected glucose decrease is 36 to 90 milligram per deciliter. Dextrose may be added to the IV fluid if the rate of dextrose drops faster than expected. Very important when you do the insulin infusion is insulin is used to treat the ketosis because the whole DKA happens because of insulin deficiency and excessive counter-regulatory hormones. And other things you need to pay attention to, remove the insulin pump if it's still attached. Inadvertently, you can have double insulin, one through the insulin pump, another one what you are infusing. So just make sure the patient, otherwise that will cause precipitous fall in glucose level, and that can cause cerebral edema. So rapid decrease in serum glucose can cause cerebral fluid shifts and cerebral edema. And as I the insulin can cause shift of potassium from extracellular to intracellular as a result, rapid drop in potassium that could cause cardiac consequences. So in patients with the DKA, replace electrolytes aggressively. Number one, identification and treat aggressively, very important. Typically we do 0.5 to 1 milliequivalent per kilo, max of 20 or 40 milliequivalents, but the infusion rate will be 10 milliequivalent over an hour. If you do 20 milliequivalent, do 20 milliequivalent over 2 hours, so on and so forth. Always check the level after the infusion, make sure you are not overshooting. Potassium replacement. This article, this particular table is published in Nature Reviews 2020. According to that, if the potassium level is more than 5, hold off adding potassium. If it is less than 5, add 40 milliequivalent potassium to the fluid. As I have explained, we use 20 milliequivalent potassium acetate and 20 milliequivalent potassium phosphate. Adults have a little bit different guidelines. Other important point is sodium bicarbonate bolus. Sodium bicarbonate bolus causes extracellular potassium into intracellular potassium, meaning it will drop the potassium precipitously. That will cause cardiac consequences. In addition, it increases the ketone production in the liver. It delays ketone clearance. And bicarbonate can cause paradoxical CNS acidosis. What does that mean? When you give bicarbonate, it dissociates into carbon dioxide, first forms carbonic acid and CO2 that diffuses into cerebrospinal fluid much faster than the buffering capacity of the bicarbonate. As a result, it can cause decrease in mental status. And as I've already shown before, bicarbonate bolus is associated with cerebral edema, 0.008. So there is big no for sodium bicarbonate in pediatric DKA. The bicarbonate administration is not recommended because this has not shown benefit in the resolution of DKA, and bolus administration has been historically associated with worst outcomes. Finally, intubation. Intubation cannot match physiological minute ventilation needs with mechanical ventilation. It causes loss of respiratory drive, loss of compensatory respiratory alkalosis. That results in worsening acidosis. In addition, it causes patient-ventilator dysynchrony. That means need for increased sedation, loss of neurological exam. In summary, avoid rapid bolus. When you do a fluid bolus yearly, use 10 to 20 ml per kilo over an hour. Check the labs. Bicarbonate, PCO2, electrolytes, especially potassium, and B and creatinine. Always go slow. Avoid intubation because of the deleterious consequences associated with. As we mentioned earlier, fluid bolus 10 to 20 ml per kg over an hour. Repeat one if needed. Rehydrate over 24 to 48 hours. Insulin infusion until ketones clear and anion gap closes. Add glucose if needed because insulin is necessary to get out of DKA. This concludes the seminar on pediatric DKA. As we mentioned earlier, we come up with the current information on various medical topics. If you like it, please like this one, leave your comments, and share it with medical students, private practitioners, postgraduate students, and academicians. Thanks for your time.